This recording will go over surgical management of esophageal cancer. The purpose of surgical resection vary from palliation to cure. Esophagectomy is the removal of all or part of the esophagus. An esophageal gastrostomy involves the removal of part of the esophagus and proximal stomach. The remaining stomach may be pulled up to take the place of the esophagus, or a section of the jejunum or colon may be placed as a conduit. Fistula formation between the trachea and esophagus, abscess, and respiratory complications are common. In terms of pre-op care, we want to advise the patient to stop smoking 2 to 4 weeks before surgery to enhance pulmonary function. Patient preparation may include 5 days to 2 to 3 weeks of nutrition support to decrease the risk for post-op complications. Teach the patient and family to monitor the patient's weight and I&O. A pre-op evaluation may be required to treat dental disease. Teach the patient to practice meticulous oral care 4 times daily to reduce the risk of post-op infection. Post-op nursing care focuses on teaching and psychological support regarding the surgical procedure and pre- and post-op instructions. Teach the patient about the number and sites of all the incisions and drains, placement of a jejunostomy tube for initial enteral feedings, the need for chest tubes if the pleural space is entered, the purpose of NG tubes, and the need for IV infusion. Teach the patient about regularly turning, coughing, deep breathing, and having chest physical therapy. Emphasize the crucial nature of post-op respiratory care. If colon interposition or resecting a piece of the colon to create the esophagus is planned, the patient also has a complete bowel preparation before surgery. Respiratory care is the highest post-op priority for patients having an esophagectomy. For those who had traditional surgery, intubation with mechanical ventilation is needed for at least the first 16 to 24 hours. Pulmonary complications include atelectasis and pneumonia. The risk for post-op pulmonary complications is increased in the patient who has received pre-op radiation. Once the patient is extubated, begin deep breathing, turning, and coughing every 1 to 2 hours. Assess the patient for decreased breath sounds and shortness of breath every 1 to 2 hours. Provide incisional support and adequate analgesia for effective coughing. Remind all staff to keep the patient in a semi-Fuller's or high Fuller's position to support ventilation and prevent reflux. Ensure the patency of chest tube drainage systems and monitor for changes in the volume or color of drainage. Cardiovascular complications, particularly hypotension during surgery, can occur as a result of pressure placed on the posterior heart and usually respond well to IV fluid administration. Monitor for symptoms of fluid volume overload, particularly in older patients and those who have undergone lymph node dissection. Observe for AFib that results from irritation of the vagus nerve during surgery. The patient with poor nutrition or prior radiation or chemotherapy is at risk for infection. For those who undergo more radical surgical procedures, there is a serious risk for leakage at the anastomosis or the surgical connection sites. This situation is especially true with colon interpositions because several sites are stressed by the effects of tension, poor blood supply, and delayed healing. Mediastinitis resulting from anastomic leaks can lead to fatal sepsis. Wound management is another major post-op concern. Provide direct support to the incision during turning and coughing to prevent dehiscence. Wound infection can occur 4 to 5 days after surgery. Leakage from the site of anastomosis is a dreaded complication that can appear 2 to 10 days after surgery. If a leak occurs, all oral intake is discontinued and not resumed until the site of the leak has healed. After esophageal surgery, recognize if the patient has signs of fever, fluid accumulation, inflammation, and symptoms of early shock such as tachycardia and tachypnea. Respond immediately by reporting any of these findings to the surgeon and rapid response team. An NG tube is placed intraoperatively to decompress the stomach and prevent tension on the suture line. Monitor the NG tube for patency and carefully secure the tube to prevent dislodgement, which can disrupt the sutures at the anastomosis. Do not irrigate or reposition the NG tube in patients who have undergone esophageal surgery unless requested by the surgeon. The initial nasogastric drainage is bloody, but should change to a green-yellow color by the end of the first post-op day. The continued presence of blood may indicate internal bleeding at the suture line. Commonly, an antacid will be prescribed to support the patient's healing. Provide oral hygiene every 2 to 4 hours. After conventional surgery on the second post-op day, initial feedings usually begin through the J tube. Do not aspirate for residual because this increases the risk for mucosal tearing. Before oral feedings resume, the patient is assessed for any sorts of anastomous leaks, strictures, or signs of aspirations. If no leaks are seen, a liquid diet is started. Place the patient in an upright position and supervise all initial swallowing efforts. The food storage area of the stomach has been radically decreased, and gravity is the only defense against reflux. Teach patients and or family the importance of the patient eating 6 to 8 small meals per day. Fluids should be taken between meals rather than with meals to prevent diarrhea. Please review chart 54-8 for care of the NG tube for the patient after esophageal surgery. Check tube placement every 4 to 8 hours. Ensure that the tube is patent and draining. Drainage should turn from bloody to yellowish green by the end of the first post-op day. Secure the tube well to prevent dislodgement. It's important not to irrigate or reposition the tube without physician request. And the concern is that if it were to come loose and you were to try and reposition it, that you would poke through the anastomosis or disrupt suture lines and cause more problems for the patient. Provide meticulous oral and nasal hygiene every 2 to 4 hours. Keep the head of the bed elevated at least 30 degrees. When the patient is permitted to have a small amount of water, place him or her in an upright position and observe for dysphagia. Observe for leakage from the anastomosis site as indicated by fever, fluid accumulation, and manifestations of early shock such as tachycardia, tachypnea, and altered mental status. Please review the care coordination and transition management portion on your own.